changes. Ichindi.
Good afternoon, everyone. Today we are going to continue our previous class on filariasis. Due to some technical difficulty, it could not be started on time. So let's see. Okay. So last time we did some of the things about epidemiology of filariasis, where we saw that it is called elephantiasis. Okay, most common presentation is elephantiasis. We looked at the global distribution. We saw how filariasis has got a very huge social impact and familial discord, leading to psychological distress also. So not only it's a physical debilitating disease, but also it has got a huge social impact. And then we saw the different forms of filariasis, lymphatic and non-lymphatic. Lymphatic being caused by Filaria bancrofti almost 80% of the times, and to a lesser extent, particularly in South Indian states, caused by B.malayi and B. timori. In non-lymphatic forms, we saw that there was the subcutaneous form and the serous form. For the subcutaneous form, it is caused due to Oncosarca volvulus, loa and Manzanella species, and serous form also caused by Manzanella species, but different subtypes. Okay, so we looked at the history. We saw which are the parts which are most affected due to Filaria bancrofti, due to loa, due to river blindness, and then we saw the distribution, global distribution of Filaria bancrofti filariasis. Okay, so I guess we covered this also in epidemiology, how a worm would look like, how Filaria bancrofti worm differs from the B.malayi worm. Malayi worm is usually smaller than the bancrofti worm, and it has double stylets at its end. I hope you remember that. Okay, and then we looked at the life cycle, how it enters the lymphatics and how it enters the lungs, causing complications there. Then we saw this life cycle. Okay, and then we saw the periodicity of Filaria bancrofti and Malayi in India, which shows nocturnal periodicity between high activity between 10 p.m. and 4 a.m., which lays the basis for nocturnal blood examinations. Okay, I think we had covered up to reservoirs. So let us see the host factors. Okay, man is a natural host. All ages in humans are susceptible to Filaria bancrofti infection. Infection rate rises with increasing age. Why? Because humans are not very well protected above the age of 20 to 30 years. They have more outdoor activities. They like to stay outdoors. And they are more exposed to the bites of mosquitoes. That is why it is more in higher age groups, more than 20 years. Whereas kids and women, sex also, you can see it is higher in men, where in rural areas it is a practice that men sleep outdoors. Okay, and they are usually not protected against the bite of the mosquito. Whereas women, children, they like, geriatric people, they like to stay indoors, and younger age groups definitely they stay indoors. So that is why they are less susceptible. But if everybody would have an outdoor habit, I would say everybody would be equally susceptible. Then you look at the migration. Migration causes extension of filariasis into areas which were previously non-endemic. Okay, so once an infected person migrates to an area where earlier the disease was not existent, so then you would see that he brings the disease to a new area, right? So that is why we say that migration plays a very important role even in dengue or even any of the vector-borne diseases where man is the reservoir or man is the natural host. He can carry the disease with himself into non-endemic areas and cause a spread of disease if the vector and suitable environment is present in those areas. Then you look at the immunity. Humans are resistant to infection after many years of exposure. Okay, so once they have been exposed, then after that they cannot have a second exposure, but sadly the first exposure itself can bring its impact if it is not treated or controlled adequately. Okay, then you look at the environmental factors. Now, for all the vector-borne diseases, environment plays a very, very important role. Climate plays a very important role because of the fact that the rainfall, humidity, temperature, these three factors in climate, they determine the longevity of the mosquito, the breeding habits of the mosquito, and secondarily, they also determine how the parasite will develop or it will have its um, viviparous cycle within the uh, uh, gut of the mosquito. Okay, so you see the maximum prevalence is observed at a temperature of 22 to 38 and a very high humidity of 70 degrees. So this kind of temperature usually is present in the tropical environment during the rainy seasons when the lower temperature you can see goes down to about 22 degree and the highest temperature touches about 40 degree, but it is never more than 40 degree, and humidity is very high. Okay, more than 70% or more than 70%. So this is the ideal breeding ground for the mosquitoes, and when the mosquitoes breed, then within their gut the parasites also breed. So second thing in environment is how the towns are planned or improper town planning or drainage or all these things. Okay, so rapid urbanization is happening in most of the developing countries including India, which causes inadequate sewage disposal, which causes pools of water here and there, and it causes breeding, mosquito breeding. And even if you see clogged drainage or blocked drains, again a result of improper town planning, mosquitoes, they breed profusely in polluted water. Okay, so these are some of the characteristics of uh, filariasis vectors. Okay, so you see in environmental factors, you can talk about the natural environment, seasonality, and then you can talk about the artificial human environment which is created in the form of urban areas, in the form of improper drainage or pollution and all these things. Okay, so these are some of the important factors contributing to the growth and proliferation of mosquitoes. Then you see, look at the socio-economic factor. On one hand, I am telling you that it is a disease of the rural areas because in the rural areas people stay outdoors, but in many of the urban slums and areas, urban areas where the socio-economic background of the people is not so strong, especially in construction sites where you would see workers living in temporary sheds and so many people who live in slums. So it is a major cause of disability amongst those people, and it is associated with urbanization, industrialization, migration, poverty, illiteracy, poor sanitation. All these things are contributory factors because of the core fact that people who have all these factors associated with them, migration, poverty, illiteracy, living in poor sanitation, they are generally belonging to the lower socioeconomic status, and they do not have much knowledge about the disease. If they have knowledge, they do not care much about the disease until it happens and affects them, or even if they are affected with the disease, they wouldn't know because they don't have proper access to healthcare services. They are usually daily wagers, laborers, so they are scared to lose their wages for one day if they have to go for a checkup or for some health consultation. So these are some of the socio-economic factors. Then you see, we have already seen what kind of impact it produces, filariasis produce on the health of the individual. We shall see further in clinical features and presentation, and economic status because of disability. and people lose their jobs. They are not able to continue with whatever they are doing, and they have to just sit at home. Okay, and across the world, you saw that it affects many countries which are tropical in their location, and that's why it's a major disease across the world also, not only in India. Care for filariasis, reports say, cost millions of dollars across affected people in the world. Okay, so it has major socioeconomic implications. That is why it is a part of the, let's say, vector-borne disease control program. There is active case finding, and early diagnosis and treatment is the goal for active case finding under the program. So vectors we've been talking about for Wuchereria bancrofti, Culex quinquefacius, fasciatus or fatigans, Culex fatigans, you may remember, in urban and semi-urban areas is the main vector. Okay, in rural areas of Africa, however, other vectors like Anopheles mosquito have been reported, and in Pacific Islands, Aedes mosquito also has been reported as a vector for filariasis. Now, when you look at B.malayi and Mansonia species and other like annulifers or uniformis, so they have also been implicated to a lesser extent. You know that. Okay, so then common breeding habits for Culex are they breed in cesspools, they breed in soakage pits, they breed in ill-maintained drains. That is why I said that the vector breeds in polluted water, in septic tanks, in open ditches, in burrow pits. So this is in contrast to Aedes mosquito, which breeds in fresh water. So wherever there are dirty water accumulations, especially in the urban or even in the rural areas, okay, that have not been maintained for a very long time, dirty muddy water, Culex likes to breed there. If it is Mansonia, which is indicated in B.malayi infection, so it is mainly breeds where there is a lot of aquatic vegetation. So aquatic vegetation is usually present in many stagnant or old ponds in the form of pistia plants. Okay, so that is why even in vector biology, you must have read a very important role of clearing of pistia plants. Why? Because Mansonia species likes to breed in aquatic vegetation. Okay, they take oxygen from the roots of the plant, so they like all these aquatic plants. So this is septic drains containing stagnant water, dirty water. So this is the adequate breeding ground for your Culex, and I'll show you in the next one. Okay, so you see all the mosquitoes resting here along the walls of the drains, adult mosquitoes, and these drains are full of larvae. So dirty water is a breeding ground for Culex mosquito, and these are the pistia plants. You may see some lakes in villages, or when you cross some area where water has been stagnant for a very long time, and the whole lake is covered with green colored plants like this, thick leafed plants. So unlike other larvae, Mansonia larvae, they like to cling to the roots of these plants, and then they derive their oxygen from the roots of these plants. So if you clear the roots, or if you clear the plants, or if you clear the pools and lakes of all these pistia plants, then at least you take care of Mansonian larvae. Okay, so then how the disease is transmitted? You very well know now that it is transmitted by the bite of an infected mosquito. Transmission also depends on the man-mosquito contact. Because the man has to be infected when the mosquito bites the man. So infective biting rate, at what rate an infected man is getting bitten, determines what will be the rate of transmission. So as many as 15,000 bites are necessary to produce infection. So it does not happen with just one bite. Okay, so 15,000 bites are necessary so that sufficient load of parasite gets injected into the human blood, and then it produces infection. So that means a man should be sleeping outside and continuously he is being bitten by infected mosquitoes throughout the night. So then probably over a period of a week or a month, maybe he will get 15,000 bites and then he will get infected. So please remember this. It depends on the number of infective biting. So that is why this term infective biting rate is written here. Now, if we look at the incubation period, there are two forms of incubation period in this disease. One is intrinsic, which happens within the humans, and the second is extrinsic, which happens within the mosquito. So, in the intrinsic period, which happens within humans, there is a pre-patent period and a clinical period. During the pre-patent period, there is inoculation of infective larvae and the first appearance of detectable microfilaria. Okay, so this is also called latent period. You can say the time when the parasite enters the body to the first symptom, but here it is first appearance of detectable microfilaria. In clinical, there is inoculation of infective larva to the development of clinical manifestations, and it ranges between 8 to 16 months or even longer than that. Okay, so you have detected the microfilaria, they have been injected into the bloodstream or lymphatics of the human being, and they develop clinical manifestations in the form of swelling of limbs or swelling of any dependent parts. So that is a clinical manifestation. So this is pre-patent, this is clinical. Then in the extrinsic incubation period, which happens within the mosquito, it is determined by entry of microfilaria to the in the mosquito through its bite to the appearance of infective larvae, and usually this takes about 10 to 14 days. Okay, so these are some of the definitions which are used to define incubation period, and you must note that microfilaria does not multiply in the mosquito, it just grows in size. Okay. So then let us look at some of the clinical features and how to diagnose. Now, main clinical features that cause non-lymphatic filariasis, main parasites are, you already saw in a previous slide, they are Loa onchocerca volvulus, which causes river blindness. So in loasis, worms live in subcutaneous tissue and cause intermittent development of localized areas of erythema, angioedema on the extremities. So these are the common presentations. You do not see let's say elephantine limb. Okay, you do not see a very huge presentation. Okay, but it is very infrequent in India because the parasite is not present in India much. Okay, so these are mainly in the African subcontinent where you see them more, in other tropical countries. So they live in the subcutaneous tissues and they cause local swellings. Okay, so that is Loa. In onchocerciasis, there is severe pruritus and subcutaneous nodules. So these nodules contain the adult worms. Okay, and if they are within the eye, they can cause conjunctivitis and photophobia. In some patients, because of continuous irritation and foreign body let's say reactions, there is neovascularization, there is keratitis, and there even may be corneal scarring, and it may lead to blindness, and that is why this is commonly called river blindness. Why river? Because generally it occurs to the people who live along the banks of a river, where in tropical regions where the condition is suitable for let's say multiplication of vector and the development of parasite within the mosquitoes, and blindness. Why? Because it is causing ultimate corneal scarring and leading to blindness. So onchocerciasis causes river blindness, and the mechanism is described here. In the eye, they cause conjunctivitis, photophobia, neovascularization, keratitis, and corneal scarring leading to blindness. Now, the main parasites which cause lymphatic filariasis, again I am emphasizing here, are W.bancrofti, causing 80% of the symptoms or 80% of illness in the Indian subcontinent, and to a lesser extent up to 20% it is B.malayi. B. timori is even lesser, less than 2% or 3%. Okay, so most people among the infected individuals, they don't know that they have lymphatic filariasis, because the symptoms you saw that the latent period or the infective period, incubation period for the appearance of symptoms is very late. And secondly, they don't feel any symptoms until after the adult worms die. So when the worms are active, they cause several reactions within the body which are allergic in nature. Okay, so they usually tend to discard it as allergic manifestations, and then after the worms die and the worms get accumulated, the worm load increases inside the body, they start feeling the symptoms, because then it clogs the lymphatics. Okay. Now, this disease is usually not life-threatening, but it can permanently damage the lymphatic system, causing great suffering, disfiguration, and disability. Now, how this happens? When the adult worms get collected on the let's say valves of not valves, I would say inlets of lymphatic system, then there is a failure of the lymphatic system. It cannot be drained. Okay, so there is lymph collection mostly in the dependent parts of the body, and it leads to swelling. These are some of the dependent parts of the body: arms, legs. In the women, breast enlargement can happen. Okay, so huge collections are there, and these are usually pathological in nature. Swelling and decreased function of the lymphatic system makes it very difficult for the body to fight against germs and infections. So that is why you also see that in these dependent, in these portions where edema has occurred, or filariasis has affected the limbs or the dependent parts of the body where there is decreased function. So these sites are also prone for other infections. And what are these other infections that we are talking about? These are mostly bacterial skin infections that lead to hardening and thickening of the skin, and on top of that you will see multiple ulcers and all these things which are usually bacterial in nature, but fungal infections are also equally prevalent. Okay, so this is called elephantiasis. I already told you, because elephant legs, the legs are swollen to enormous sizes, and they resemble the legs of an elephant. So disease manifestations can be divided therefore into lymphatic filariasis, and second is occult filariasis, where you do not appreciate the symptoms very much. Now, in lymphatic filariasis, there can be 4 stages. First is asymptomatic amicrofilaraemia. So that means the person in this stage will not have any symptoms, and he will not show microfilaria on a blood smear also. Second is asymptomatic microfilareemia, where the patient is asymptomatic, he does not have any symptoms, but microfilaria are present on the night blood smear. Third is stage of acute manifestations, when suddenly there is a microfilarial burst inside the body, and acute symptoms start presenting in the form of let's say nodules, itching, redness, and all these things. And second, last is the stage of chronic obstructive lesions. So all people who present with filariasis would have gone through all these 4 stages. Okay, so in asymptomatic microfilareemia, I just now told that there are no microfilaria larvae found in blood, and there are no clinical manifestations. Most of the people would be in this stage, they would not know, and mainly in the endemic areas where transmission is slowly occurring to a larger number of people. In asymptomatic microfilareemia, the next stage, blood is positive for microfilaria, though there is no clinical manifestation, and this is a very important source of infection in the community. Person does not know, he is going around. Okay, mosquitoes are biting him, they are taking the microfilaria in their gut. The cycle is being completed, and it is being injected through infected bites to another individual. So this is a very dangerous stage. It is almost, you can say, the stage of COVID, where you don't know in whose contact you are right now. Okay, so these are usually detected by night blood examination, and the target of night blood examination is ideally to identify microfilaria circulating within the blood. Patient may be asymptomatic, and that is why we don't rely on symptoms. We just go, we survey everybody, and then we find out what is the rate. Okay, how many people came positive, and we define the endemicity. If the rate is high, I will show you later, all the people in that community are put to treatments, because we don't know who the mosquito has bitten and who he hasn't bitten. Okay. Then there is the stage of acute manifestations. In this, there are recurrent episodes of acute inflammation in the lymph gland and vessels. So these people may present with filarial fever. They may present with lymphangitis, lymphangiovarics, lymphoragia, lymphadenitis, lymphedema of various parts of the body, and epididymoorchitis in males. So these are some of the common presentations which are related to blocking or acute inflammation of the lymph glands. And then there is the stage of chronic obstructive lesions. You already saw that. Most of the pictures that we see are the stage of chronic obstructive lesions, when the patient finally comes to know that he has been infected with filariasis, and this is a disease which is not going to go away. So it usually develops after 10 to 15 years from the onset of the first acute attack. So look at the long latent period when you finally are able to see chronic obstructive lesions. If I have been bitten today, then I would only know after 15 years that I was bitten by mosquitoes who had filariasis, who had the filarial parasites or something like that. Then due to fibrosis and obstructive of the lymphatic vessels, it causes a permanent structural change. That is why it is irreversible. It is a residual damage that is done, and main features, clinical features in this stage, in the final stage, are hydrocele, because that is also a dependent part of the body, scrotum, then elephantiasis, chyluria. And if you remember the history, microfilaria were first demonstrated from the chyluria of a filariasis patient. Okay, so these are the 4 stages. So look at these pictures. Here you see elephantiasis, okay, in the leg. This you can appreciate. This is swollen lymph glands, okay. Then hydrocele of massive size, okay. And then you see enlarged fingers also, okay, swelling in the fingers. So these are some of the presentations which have been reported for filariasis. Now, elephantiasis may affect legs, arms, scrotum, penis, vulva, breast in the order of decreasing frequency. So, legs are most affected, arms are less affected, scrotum is even lesser affected, okay, and so on. But in Brugian filariasis, it is generally similar to Bancroftian filariasis, but genitalia are rarely involved, except in areas where mixed infection occurs. Now, you already saw that Brugian filariasis, it resembles kind of Bancroftian filariasis symptom, but they are less severe in nature, okay, and more localized. So that is why genitalia are rarely involved there. If you look at occult filariasis, then the clinical condition, not directly due to lymphatic involvement, but due to hypersensitive reactions to filarial antigen. That is, microfilaria are not seen blood, but present at the affected site. So you see that there is localized presence of filaria, and it causes some local reactions, okay. And so if you do a night blood smear, you may see, you may not see, because it is not generally present in the bloodstream or not generally present in the lymphatic system. So you may not detect. So that is occult filariasis. Occult means hidden filariasis. So clinical condition is not directly due to lymphatic involvement, but due to hypersensitive reaction to filarial antigen, which are present in the localized site. Now, see this tropical pulmonary eosinophilia. Sometimes you see some patients who come to the OPD and you must have seen that they present with itching in some area, in the eyes or in the body or somewhere, and then you detect a lot of eosinophilia in them. And you must have often wondered why you treat eosinophilia with DEC. So it is for the same reason. It may be a suspect of occult filariasis, and these patients improve significantly with DEC because the microfilaria which are present in the targeted areas, they are acted upon by DEC and they are killed and they are flushed out of the body. They do not proceed to clog the bloodstream of the not bloodstream, sorry, filarial lymphatic system of the patient. So this presents with low grade fever, loss of weight, anorexia, pulmonary symptoms such as nocturnal cough, dry cough, dyspnea, wheeze. Okay, so if any patient presents with chronic low grade fever, loss of weight, and he presents with dry nocturnal cough, always you must order eosinophil count, and then if it is very high, then you can suspect tropical pulmonary eosinophilia, which can be a presentation of occult filariasis, and it is treated with DEC. Now, mainly due to suppression of the immune response to the microfilarial antigen, so that microfilaria antigens are filtered out and destroyed in the lungs with allergic inflammatory reaction. So that is the pathophysiology behind tropical pulmonary eosinophilia, which is a form of occult filariasis. Now, how to diagnose filariasis? It mainly depends on the clinical features. It depends on the history of exposure in the endemic areas, and it also depends on the lab findings. Now, various lab tests are conducted, and the aim of all those lab tests are demonstration of microfilaria in the peripheral blood. If it is urine, then demonstration of microfilaria in chylous urine. If it is hydrocele fluid, then you demonstrate microfilaria in hydrocele fluid. If you are taking biopsy from some of the nodules, because I told you one of the presentation was nodules and local erythema. So if you are taking biopsy specimens from those nodules, then you are able to demonstrate adult worms in those biopsy specimens. Apart from that, you can also do serological tests where you can demonstrate antibody to filarial antigens, or you can directly detect antigens in the blood. So these are the various types of laboratory tests, mainly aimed at either determination or demonstration of microfilaria from the specimen, or demonstration of some antibody or antigens within that specimen for microfilaria. The skin tests are done with microfilarial antigens. So this is indirect evidence such as eosinophilia. So when you inject filarial antigens in the skin, there is eosinophilia. So that also tells you that the person has been infected with or there is circulating filarial antigen within the body of the person. Occult filariasis is diagnosed mainly by clinical features. Okay, there is a raised blood eosinophilic count to the rate of 3000 per cubic millimeter to 50,000 per cubic millimeter. Okay, so this is the raised eosinic count. There is elevated IgG levels. If you do a chest radiography, because the person might present with dry cough, so it may show mottled shadows which resemble miliary tuberculosis. Okay, so tuberculosis, the person will give a history of coughing throughout the day. It may be a wet cough, it may be a dry cough, we don't know. But in filariasis, the person will give you history of dry cough at night mostly. Okay, then if you do some serological tests with filarial antigens, they come out to be strongly positive, and there is a DEC challenge test also. So if you treat that patient, give a test dose of DEC, then there is a first there is a positive test, and finally the infection gets controlled. So that is why DEC is used in the treatment of tropical pulmonary eosinophilia. So this is the chest X-ray showing mottled appearance all over. Okay, similar to miliary tuberculosis. Now, how to prevent and control? We shall see some of this, and partly I will cover it in the next class because we started late today. So, uh, okay. So, it was identified as one of the 6 eliminable infectious diseases, mainly because of advances in recent treatment methods. Okay, and for integrated vector control, which would control filariasis also. This is one disease which cannot be transmitted in any other way other than bite of an infected mosquito. So if you are able to control the mosquitoes, then you are able to control this disease. Okay, and then there were improved techniques for diagnosing filarial infections. So that is why in as early as 1997, World Health Assembly, they adopted a resolution calling for elimination of lymphatic filariasis as a as a public health problem worldwide. So it is not only in India that is targeted for elimination; it is across the world. Now, if you have read the national health policy, maybe you can just jot down, is it listed there, and if it is listed there in national health policy, then by which year do we aim to eliminate filariasis? So you might recollect that earlier it was 2015, then it was moved to 2017, and then now it is 2020, but 2020 is also over. So far there are no reports about elimination or anything, so we might have to wait a year or two and strengthen our diagnostic capabilities and mass treatment with DEC. Okay, so how to diagnose filaria in the community. I told you that night blood surveys are the are the main element in diagnosis. So the first thing is you do mass blood surveys, and that is through night blood surveys. So what do you do in night blood surveys? You go to the household of the individual after 10 p.m. at night. Okay, 10 to 4 is the time. So within 10 p.m. and 4 a.m. you have to complete. If you are not able to complete, you go the next day. So it includes a thick film. Then there are membrane filter concentration methods, which are called MFC methods. And finally, if you are not able to detect anything, you give a DEC provocation, 100 milligram orally, and then you collect a blood smear. With DEC provocation, the microfilaria become hugely active, okay, initially. So you are able to detect them in the blood smear. Second is clinical survey, where you will do a survey of the clinical signs and symptoms. Okay, and third is serological survey, where you detect antibodies with the help of immunofluorescence or complement fixation test. If you're trying to detect the antigen, you can detect that in blood and urine. Finally, lesser adopted methods, but nevertheless they are adopted: xenodiagnosis and entomological surveys. So mosquito collection is done from the houses, then dissection of the female vectors is done to identify various developmental forms, and also you do an environmental study along with the entomological survey to see what are the various breeding places, are they present in and around the houses, what is the mosquito count there. Okay, so all these things are components of the filaria survey. Mass blood survey, night blood examination, clinical survey, how many people are suffering from clinical manifestations in the area, serological test to detect antigens, antibodies, xenodiagnosis, and entomological surveys. If you look at the modes of prevention, you can easily understand we have to go through the 3 modes of prevention, namely primary, secondary, and tertiary. In primary prevention, sorry, we try to educate the community by providing health education on how to protect yourself from bites of adult mosquitoes and what are the various signs and symptoms of disease. Okay, and how it will present later in life and lead to economic and social disability. Okay, then you can tell them about environmental modifications you can do, because you have done an environmental survey. You can always share the results with them, and then educate them about the uh, uh, detrimental effects of having polluted water or stagnant dirty water around their houses, and environmental benefits of environmental cleanliness. So these modifications they can always be told about with which they can prevent a lot of diseases including filariasis. Okay, and then you can also tell them nutritional interventions, because I told you that immunity also plays a role in the initial infection with the microfilaria. Okay, and finally you can talk about specific protection. Then in secondary prevention you talk about early diagnosis and treatment, and in tertiary you aim at disability limitation and rehabilitation. So let us see, secondary prevention is done through chemotherapy. Okay, so either you can have selective treatment for a infected individual, so you treat by giving DEC. Okay, you treat by giving ivermectin, or there are some other modern drugs also apart from DEC and ivermectin. In chemotherapy, you can also do community treatment in an endemic area where you suspect that a large number of people might be infected. Okay, so here you do mass therapy with the help of DEC medicated salt at the rate of 1 to 4 gram per kg. Okay, so this is also given at night time. So a health worker has to go and always ensure that the tablets have been taken by all the family members. Okay, so this is for chemotherapy. Selective treatment, community treatment. Selective treatment is with DEC and ivermectin, and in some cases albendazole and other drugs are also given. Okay, in community treatment, this is mainly using DEC medicated salts. And you talk about vector control, because only chemotherapy will not help. You saw that it depends on the numbers of infective bites or infective biting rates. So that is why vector control also is very important. You talk about integrated vector control, you talk about anti-adult measures using residual sprays or space sprays, you talk about personal prophylaxis, and you talk about anti-larval measures where you talk about chemical control. Okay, uh, what chemical control we shall see just now. Removal of pistia plants. Why? Because you saw that Mansonia species, they breed well, or larvae, they stick together to the roots of pistia plant. So this plays a very very important role in control of Mansonia. And sanitary measures, because you saw that they breed in polluted water. Now, how to give DEC? For Bancrofti and filariasis, you give 6 milligram per kg body weight per day orally for 12 days in divided doses. Okay, so morning, evening. Brugian filariasis, you give 6 milligram per kg body weight per day for 6 days. Okay, so this is lesser in intensity, so half the number of days. This is twice the number of days. So in dose schedule is prescribed usually in the national program. So if it is less than 2 years, it is not given. Between 2 to 5 years, 100 mg is given. Between 6 to 14 years, 200 mg is given. More than 15 years, 300 mg is given. What are the common toxic reactions to the drug that you need to explain while giving the drug to the individual? Now, due to the drug itself, the person may have headache, he may have anorexia, nausea, abdominal pain, vomiting, lethargy. And due to, because DEC causes the destruction of microfilaria within the body, some fever, local inflammation around the dead worms, pruritus, skin inflammation, itching, all these things may also happen. So they need to be explained to the individual beforehand that these are the reactions which are very likely to happen after the consumption of the drug, because worms are dying inside your body and then they will be eliminated. And these are some of the reactions to the drug. If they are profound in nature, then you have to switch to an alternative drug. Now, ivermectin is a semi-synthetic macrolide antibiotic with broad spectrum activity against nematodes and ectoparasites. This is what you already know from your knowledge of uh, pharmacology. So this is usually given combined with albendazole. Okay, this is never, ivermectin is not given alone in the national program. It is said that you combine ivermectin with albendazole for greater efficacy. So 400 milligram of albendazole and 200 microgram per kg of ivermectin is given, administered. Even DEC is now combined with albendazole, and you give DEC 6 milligram per kg combined with albendazole 400 milligrams single dose. But it is not given in countries where onchocerciasis occurs. Okay, so this is not a treatment for liver blindness. So there you give DEC or ivermectin. You do not give albendazole. Now this treatment is instituted as a annual single dose 2-drug regimen for 5 consecutive years. In addition, why albendazole has been added is that it has the additional advantage of eliminating diverse intestinal worms. So not only it acts on filarial worms, there are other worms also within the human body in the intestine, like roundworms and all these. So they are also simultaneously eliminated by adding albendazole. Okay, so these are this chart shows you the benefits of giving ivermectin and DEC alone, and when you combine 1 and 2 drug regimen, what happens to the blood microfilaria levels. Okay, so months post treatment is described here. Okay, so here you see that when ivermectin is given alone, initially there is high level of blood microfilaria, okay, 100% let us say, and then when you go later in months, then this pink one tells you 12 months, okay, so 12 months you see some of the residual microfilaria. Blood microfilaria level is still present after the end of 12 months, so that is some worms are left. Okay, so this is with ivermectin. When you give DEC, initially there is 100% level, it comes down to 0.5, okay, in the first let's say uh, okay, in the first 15 days, then it goes to it stays between somewhere 0 to 20, 0 to 10%, I would say, post treatment. Okay, and then you see that after 12 months of treatment, there are still some microfilaria left. But when you give ivermectin and DEC together, combined therapy, so that has shown results that initially, of course, there will be 100% of the worms, but then it is flat. You do not see any resurgence or re-emergence of microfilaria in the blood at the end of 12 months also. So that is why this is stated to be evidence-based and a highly effective therapy, combined drug therapy against microfilaria. What happens when you give albendazole also? Okay, so here you are giving albendazole alone, does not have much action against microfilaria, though it comes down at the end of let's say this red one is 15 months, so it starts coming down and it comes down, but when you give it with DEC, the levels are much lower at the end of 12 months. When you give with ivermectin, still lower. So that is why it is said that ivermectin is an advanced drug over DEC. But many people do not tolerate ivermectin, so they have to be given DEC. Moreover, ivermectin is a costly drug. So first you try with DEC. If he does not respond, then ivermectin becomes the second line of drug. And when you give ivermectin and DEC together, so results of ivermectin and albendazole are better than ivermectin and DEC. I would say they are similar to albendazole DEC and ivermectin DEC, almost similar results at the end of 11 to 15 months. So you can compare these graphs here. So again, this is the basis for adding albendazole to the treatment. Now, chemical control, you already know, you already have read it many times. Okay, you must have been told in the National Vector-Borne Disease Control Program that you can use mosquito larvicidal oil, you can use pyroxene oil, you can use organophosphorus larvicides. So please read all this in the book and the amount to be used. Health education, you know, to find the knowledge levels. Okay, and they saw that okay, a survey was conducted in one endemic district of Odisha, and they found that many lymphedema patients, they visited PHC for treatment of acute attack. Many workers did not know the importance of foot care, and knowledge of workers was below the desirable levels. So they inferred that village health guide should be trained and involved in filarial management and control activities, because this is mostly happening at the rural area level or remote areas where only government health functionaries have access. So they must be well trained to identify and care for the filaria patients. Okay, these things maybe I'll take them up in the later class. So you see here, wash with clean water at room temperature. How to take care of the filarial lymph. Okay, do not wash with warm water. Why? Because sensitivity is less, and then it might get burns, or if ulcers are there, then there are high chances that bacterial infection will take place. Okay, so these are some of the things that I will show you in your next class. I think you are already exhausted. Please read up vector control measures for filariasis. Thank you.